All right. So good afternoon, everyone. My name is Farahaba Lakhdir. I'm one of the pediatricians here at the outpatient pediatric clinic, and I'm going to be building on the first talk that we had last month, given by Miss Mrs. Lavery. We have no disclosures. So my objectives today will be to briefly review the elements of medical decision making and some key definitions that are used, discuss changes in time intervals and prolonged time codes, and also provide examples of how to code to your advantage. So just as a reminder, code selection now is not based on um, the history and physical exam as it was previously. That doesn't mean that we don't examine the patient, but it just means that that will not be what the coders are or the auditors are going to be looking at. Of course, we take the history depending on what the patient presents with and the physical examination also. The code selection is now based either on medical decision making or the pediatricians or the physicians or the qualified health professionals' total time on date of the visit. Only office-based services have been affected. Well child codes 99381 to 99385 and 99391 to 99395 have not been affected. So why was this change initiated? Because previously the guidelines were very confusing and burdensome. And then there was pressure from insurance companies and auditors to follow the evaluation and management documentation guidelines from 1997, which contributed to physician burnout and decreased the emphasis on patient care. With electronic health records, it led to note bloat. And then now providers get credit for what they do. So there's 4 types of medical decision making, which is not different from previously. Straightforward, low, moderate, and high. So you determine the level of the of MDM based on the highest 2 of 3 elements. So you address the number and complexity of problems, the amount and complexity of data, and the risk of complications from your management decisions. So this would be associated with the patient's problem, the diagnostic procedure, treatment, and it includes possible management options that were selected and those that were considered but not selected. So documentation is extremely important. Now, this is just a detailed slide of the number and complexity of problems addressed. So minimal would be the 99202, 99212, low 99203, 99213, and then the moderate, which would be the level 4, and high would be level 5. And I'm going to talk about each of these in just a minute. The amount and complexity of data. So this is the second element that we use. And again, level 2 that requires minimal or none. Level 3 must meet at least 1 out of these 2 categories. So either you have an independent historian, or in category 1, you have to have 2 from the following to qualify for a 203 or 213. The good thing is that new patient and established patients really require the same amount of elements, same amount of data. Okay. Then you have the moderate, which requires 1 out of 3 categories. So if you're going to choose category 1, then it has to have any combination of 3, right? Oops. And then category 2 is the independent interpretation of tests and discussion method. All right. And then this is risk of complications. Again, with level 3, it's low risk of morbidity from additional testing or treatment, and moderate risk of morbidity from additional diagnostic testing or treatment, which is level 4. And level 5 is high risk of morbidity from additional testing. And we'll talk about this really quickly. So minimal problem is a problem that may not require the presence of a physician or other qualified health practitioner, but the service is still provided under the supervision of the physician or other qualified health practitioner. So an example of this would be a nurse doing a blood pressure check, which is normal and you didn't need to do anything, or a PPD reading which was negative and you didn't have to do anything. So this would be a 991. Level 2 would be a self-limited or minor problem, a problem that runs a definite and prescribed course. It is transient in nature and it's unlikely to permanently alter health status. For example, a newborn who comes in for a weight check and is gaining weight without any issues, you would code this as a 99212. This was a learning process for me because I thought that all of those would be a 99213, but this would be a 99212. If the baby comes in for a weight check, the second visit, the baby's gaining weight very well, mother has no questions, there's no jaundice, so this would be a 99212. Or if a patient comes in with an otitis media that has resolved, just comes in for an ear recheck. And this is just for the complexity of problems. Then we have level 3, which is the uncomplicated illness or injury. So this would be a recent or a new short-term problem with low risk of morbidity for which treatment is considered. There is little or no risk of mortality with treatment, and full recovery without functional impairment is expected. For example, allergic rhinitis, a simple sprain, cystitis, otitis media, pharyngitis. All right, so level 4, this would be an acute illness with systemic symptoms, an illness that causes systemic symptoms and has a high risk of morbidity without treatment. General symptoms. Now, this is very important. If you had a patient that came in with a pharyngitis and had a fever, negative strep test, this would not qualify as a level 4. This would just be a level 3. It would be an acute, it would be an acute minor illness. But a patient who came in with a pneumonia or pyelonephritis or colitis, that would qualify as an acute illness with systemic symptoms, which would be a level 4 for your problem with rats. Chronic conditions are those that are expected to last a year or until the death of the patient. If there's exacerbation, progression, or side effects of treatment, that increases the complexity of your NDN. So if this is the asthma that is out of control, or an anemia that has worsened, then that would be a level 4, okay? An undiagnosed new problem with uncertain prognosis, or in the differential diagnosis that represents a disease or condition that has a high risk of morbidity. So this would be a level 4, such as malignancy and autoimmune disorder. This is the undiagnosed. So if you're suspecting malignancy or if you're suspecting GIA or something to that, and then that would be a level 4. So a level 5 would be an acute complicated injury that requires treatment. That would include evaluation of body symptoms not directly part of the injury organ, or if the injury is extensive, or treatment options associated with risk of morbidity. In the outpatient world, we probably don't see this as much. Something that urgent care and ER would see. So head injury with loss of consciousness or motor vehicle accident with multiple injuries would be a level 5. And then this is what we might see in the clinic: acute or chronic illness that poses a threat to life or bodily function. For example, if an infant comes in respiratory distress or sepsis, and you have to send them to the emergency room for evaluation, that would be level 5 for the complexity of the problem. All right. So amount of our complexity of data reviewed. So an order, it's very important, an order or review of a test panel. So if you ordered a CBC, that's counted as one test. And you don't count, and if you ordered a CBC, an ESR, a CMP, those count as 3 tests. Right? So each test ordered or reviewed is counted as a data point. If you review a test at one visit, you cannot count it again at the next visit. The exception to each test being counted as a data point is that if it is done in clinic, you can only count it once. So if it's a point of care, UA, hemoglobin, a flu screen, you ordered it and you reviewed it, you can only count that as one data point and not 2.
because you will be charging that post point of care. You will actually be charging for that. So you can only count that one. Then what is an appropriate source? That includes professionals who are not qualified health professionals, but involved in management of the patient. For example, a teacher, social worker, case manager, an external physician or nurse practitioner or PA. So discussion with family of care givers is not really used in determining the level of MDM, but may be used when coding with time. Okay, so what is an external record? An external record, a communication, or test are when you review a test or such from a qualified health practitioner that's not in the same practice or is a different subspecialty or specialty. For example, if you review notes from urgent care, from ER, even if that is at Carilion, that would count as one data point. Independent historian has to be a parent, a guardian, a witness, and then you should document who you used and why. I usually would just say a history obtained from parent because, or from father, because child is only 2 years old and cannot provide a history. That's my spot test. And then there's something called independent interpretation. So you can interpret a test that has a CPT code. Somebody else ordered that test, and there's but you are now looking at it and reviewing it for the first time. Or it's an X-ray that was reported by a radiologist, but you are looking at it and you put in your interpretation that, I think there's something in there. But this does not have to be a complete report. So this can be counted as a data point. Okay. So the level of risk is based on the consequences of the problem that you're addressing at each encounter. So the start of the illness or functional impairment that is expected to be of substantial duration. And then social determinants of health, such as, if you address like food or housing insecurity. It can also be something that you wanted to do for the patient. For example, you wanted to prescribe a certain medication, but because the patient doesn't have insurance and cannot afford it, you prescribed an alternative. But that has to reflect in your documentation. And then drug therapy requiring monitoring for toxicity. These are all level 5. Okay, so the major change that happened in time is that you can select time, whether counseling dominates the service or not. In the past, it had to be 50%, but now that is not the case. It includes total time on the date of the encounter, face-to-face and non-face-to-face. It does not need to be continuous, but must be on the day the patient is seen. Time personally spent by the physician, not the clinical staff. So the nurse's time does not factor into this, and it also does not include tasks that would normally be performed by clinical or non-clinical staff. So if you were, busy and the nurses were busy and you roomed a patient, you cannot use that time for rooming the patient as part of the time that you spent with the patient. It includes reviewing test results, consultation reports, other patient information. This is different from data. This is the time that you are spending to review all. Of course, getting a history, doing the physical exam, documenting the clinical information and the record, and then independently interpreting results and communicating with the parent, family. Coordinating care when not separately reported. So if you're coordinating care and somebody else is charging for it, then you can charge for it, but it has to be done on the same day. All right. So these are just the time ranges which have changed, and I'm sure everybody. So it's of course for the new patient, it's longer time ranges for established flare. All right. So let's see if you guys can just type it in your chat really quick. True or false? Last time documentation guidelines updated was more than 20 years ago. Yes. Anybody? True? False? True? Okay. That's true. The Centers for Medicaid and Medicaid Services updated the EMDDs in 1997. Good. Okay. Next. Only codes 99202, 99205, and 99211 to 99215 are affected. True or false? Good. True. Okay.
Only office-based EM services are affected. Question 3. Interpreter is considered an independent historian. True or false? Correct. Yeah, no, very good. The parent or caregiver, okay, providing the information is independent historian. Okay. So code 99201 has been deleted and 99211 does not have any specific MDM elements. True or false? That is correct. That appears. So 99201 was deleted because there was not much difference between 99201 and 99202. And it wasn't used very often anyway. And then 99211 doesn't have any specific MDM elements like we mentioned before. All right. All right. Question 5. You can use a combination of time and medical decision making for the same office visit. True or false? It's false. True. Yeah, it's false. You cannot use both. You can use either one or the other. If you're using a prolonged service code, the 99417, then you can use only when billing by time. So an example of this is that if you see a patient with depression and anxiety and you know that you're going to spend a lot of time, then it's good to document, start the clock when you see the patient. So you spend 85 minutes caring for this patient. And this includes everything: history, physical, reviewing questionnaires, counseling, arranging for the psych appointment, making a safety plan, documenting. You can then bill, if the patient has Medicaid and or commercial insurance, then you can bill the 99417 along with the 99215. So you have to have, 54 minutes is the maximum time for the 99215. And then when you have 31 extra minutes, you could code for the 99417 2 times. It has to be exactly 15 minutes. If it's 14 minutes, you cannot add that 99417. Now for Medicare patients, they use a different code. So if you see Medicare patients, since some of our nurse practitioners and family practice residents do, there's a different code, and it has a different requirement. All right. When billing by time spent needs to be continuous on that day. True or false? Yes, it's false. It does not have to be continuous. It has to be that same day. And by that same day, it means not 24 hours from the time you saw the patient, but till midnight on that day. So if you see a patient in the morning, you sent a script, you spent 26 minutes, so you billed 99213. You haven't closed the chart yet. You were called later by the pharmacy. The meds weren't covered. You had to speak with the pharmacist and figure out what would be covered. You called in a new script, so you spent 5 more minutes. So now you can document it. So now you spend 31 minutes on the date of service. So instead of a 99213, you can now bill a 99214. So every minute that you spend with the patient or with the chart is important. All right. So coding to your advantage. Now, this is really important. I think when we first started, I was confused about how to code, but how to code by, whether we should code by time, whether we should code by MDM, and the best, the highest code that you can get is what you should be coding for. So you should really code to your advantage. So here's an example. A 3-year-old new patient comes in with his maternal grandmother, who is a primary caretaker, has a history of asthma, but does not have an inhaler at home. In the clinic, he presents with respiratory distress, it's tachypnic, 45 times per minute. So you gave him 3 neb treatments without much improvement. Gave 1 dose of steroids, and then you send the patient to the ER for admission. You spend 23 minutes with the patient, 3 minutes putting in orders, 3 minutes talking to ER physician, 5 minutes completing the note. So that's 26, 29, and 34. How would you bill this patient? What code would you do and why? Very good, Doctor. Yes, Doctor, it would be a 99205. Very good. Dr. Parmeshwar and Dr. Pierce got this one. All right, so let me go here. So this is the calculator that we use, and this is very important, and we can use that with every patient that we see, and it really helps guide. And if you do it in Epic, it actually has a record of what your thinking was. So in this case, this is a patient that comes in and has a acute illness that poses a threat to life or bodily function. So respiratory distress, that is life-threatening. So that would be a level 5 for the number and complexity of problems addressed. Elements of, and so if you were to do the complexity of data, it would just be an independent historian. So that would be a level 3, the data. But the risk of complications, now this is high because you send this kid to the ER and there would be a decision for regarding hospitalization. You thought that this kid might need hospitalization. So this would be a 99205. If you are coding with time, 34 minutes, the max that you could do would be a 99214. Or, oh, actually 99203, because with time for a new patient, it's 99203. So clearly to code by MDM in this case would be to your advantage. All right, you got that? All right, just one of them. So I think I already discussed this, but so a 13-year-old established patient comes in for evaluation of depression. You get history from the mother, do a PHQ-9 and a scared questionnaire, start the patient on Prozac, discuss potential side effects. You spent 65 minutes with the patient, 20 minutes reviewing and scoring questionnaires because the scared takes forever to score, and then documenting in the chart. So again, would you code by time or by medical decision making? Very good. Pierce and Kiana, very good. Yes. So clearly by time, this is an established patient. And if you spend 85 minutes with the patient, you can code a 99215. If you code by time, that's, and then you would add 2 of the 99417 code, right? Oh, sorry, here, because it's an established patient. All right. So this is one chronic illness with progression level 4 if you were to do a medical decision making, and data would be level 4. So the most you could get with medical decision making in this case would be a level 4. All right, because the prescription drug management is also. So it would all, by medical decision making, the most you could get would be level 4. And then with time, you can code 99215 plus the 99417 times 2. All right. Okay, so you see a 3-month-old. History is provided by parents using an interpreter since parents do not speak English. Patient comes with his first cold. Parents are very anxious. And all you advise is to use saline nasal suction and humidifier and Tylenol as needed. I was able to code a level 99214. How? MDM or time, do you think? Hannah, I will answer your question in a minute. So yes, so that's what I did. So I spent 26 minutes with the family. When you have a translator in there, and if you know that you're gonna be spending more time, even if it's just for a cold, then you should know what time you start with the patient. Because now you can code for 99214. If I was just coding for MDM in this case, it would be low because this is a self-limited problem, independent historian, and really low risk of mortality. So it would be a 99213. But if I code with time, then I can, if I spend 26 minutes, how many minutes did I spend? 31 minutes, then that would be a 99214 right here. All right. Okay, I think that was my last slide. Hannah had a question about, does assessing for suicidality not make it a level 5 due to MDM? Yes, it would, but then you cannot add the prolonged services. So to add the 99417, you have to code by time, and that is to your advantage. All right, any other questions that you can type it in? Yes, so Hannah says, so if over an hour use time, okay, so if you're going to use 15 minutes more than, if it's an established patient and you're going to be with the patient more than, if you think that you're going to be in the room for a long time, then coding by time may be better. Dr. Parmeshwar is saying the interpreter is not extra. That is correct. That's not a data point. However, the time that you spend in the room with the patient will be more when you're using an interpreter because it's going to take you longer. So in that case, it's better to code by time. Was that clear? Yeah. All right. All right. Any other questions? All right. So a newborn if a newborn has additional issues, if they come in for a weight check, but they also have jaundice and they also and you send prescription for vitamin D. In that case, if you look at this, it would be a low. You might have 2 or more self-limited or minor problems. And the independent historian. If the baby comes in for a weight check, this is the second visit, you already saw the baby for a well check in the first visit, and the baby comes in is gaining weight, and there's no issue, this is a self-limited or minor problem, in which case it could only be coded as a 99212. However, if they come in, they have jaundice, and you check a Bailey level, or if there's some spitting up or anything else, then that you could code it as a 99213. So I didn't address the additional codes that you can put in with the well checks, because when you see a well check, you can put in additional E&M service if the patient has something that you are going to address. So if you see a well check, a 5-year-old that has poorly controlled asthma, then you can code it with a well child code, and then you put in a 25 mod, you put in an E&M code, you can do a 9921314 depending on what the issue is. For example, if it's asthma out of control, it's 1 or more chronic illness with exacerbation of progression, and you're gonna do prescription drug management, then in that case, you can code it with a second code of 99214. However, if you're just calling in prescriptions for a stable chronic illness, which you would be taking care of anyway, and that well check, then that would not meet the criteria for an additional E&M. So if it's a patient that has allergic rhinitis and needs refills and came in for a well check, then you cannot really put in another E&M code along with the well check. And if you have any questions, our coding